Welcome to You and Your Health. I'm your host, Dr. David Bertone. Today's show, we're going to talk with Dr. Howard Eisenbrock, who is a neurosurgeon, about some of the recent advances in spine surgery. Spinal injuries are one of the most common things we see in my field of rehabilitation, and conservative treatment is usually very effective for a majority of spinal type injuries, back pain, neck pain, etc. Unfortunately, there does become a time where surgery is required, and we're going to learn about some of these techniques from Dr. Eisenbrock, who is a fellowship-trained, board-certified neurosurgeon who practices out of Riverview, Jersey Shore, and Bayshore Hospital. Dr. Eisenbrock, welcome to the show.
Thanks for having me.
Tell us a little bit about your background and where you were trained and how you got involved in neurosurgery.
So I did my residency in Philadelphia in neurosurgery, and then after completing residency, did a complex spine fellowship in Boston, Massachusetts at New England Baptist Hospital, and came down to New Jersey after that and been practicing here ever since.
Wonderful. And so obviously you treat more than spine injuries, so tell us what neurosurgeons will typically see in their practice.
Correct, yeah. Neurosurgeons on the whole treat diseases of the brain, spine, and peripheral nerves. The majority of my practice is in spine surgery. We're still doing brain surgery when necessary.
Yeah. So we're going to focus today about some of the advances in spine surgery and maybe some of those complex things that you might get through your training. So let's talk about a typical patient that'll come to see you. Is it just common low back pain? Is it more advanced things like scoliosis? Let's talk about, in general, the back pain patient.
Your usual back pain patient that comes in to see me, in addition to having back pain, usually has some sort of radicular or leg pain symptom, and that means that they're having pain running down into their legs related back to their spine.
Okay.
That patient usually will come in, have a full assessment by me, full workup by me, strong physical exam. If they have imaging already, we'll review it in the office. If it's not completed, I'll send them for imaging that I feel is necessary.
Okay. And you would do the same for any cervical type problems as well?
Correct.
Is that
yeah. Any problem with the spine's worked up generally the same.
Yeah.
Really based on symptoms, based on how they're presenting, based on if there's weakness, if there's any red flags that I'm worried about, such as progressive weakness or problems with your bowel and your bladder or gait dysfunction, things along those lines will prompt a more urgent administration of care.
Yeah.
For the most part, the workups are very similar.
Okay.
Yeah.
But usually the first stop is not a neurosurgeon, I would assume, right? So where most people that'll wake up with back pain or, as you say, referred pain down their leg, radiculopathy, have they tried other things first and then they get referred to you? Or how
Of course. Of course. While I do see patients and work them up initially, for the most part, most patients have already seen their primary care physician or someone else who's also worked them up. Either they were in the hospital, seeing in the emergency room, and some imaging's been obtained, or the primary care physician, or a physical therapist, or a pain management physician, and then they're referred to me.
Okay. Yeah, we had our last month's show, we talked with Dr. Patel on pain management and some of the treatment approaches there. So usually the surgical intervention will occur after these conservative approaches failed, right?
Of course.
Is that correct?
Of course.
So then you have a patient, couple of common procedures that you utilize. Let's talk about what a laminectomy is so people understand that.
Sure. If you think of the spine as a house, it has a roof. And when we think about the roof to the spine, we talk about the lamina. And contained within that, underneath the roof of the house, is where the spinal nerves sit. And when we do laminectomies, we're removing the roof to allow for more room we're allowing for more room for the nerve roots themselves.
Okay.
So that's used for treatment of stenosis or radiculopathy like we're talking about, where there's symptoms related back to imaging findings of stenosis and then clinical symptoms that the patient has. That's really where success lies in what I do. So laminectomy, great workhorse of neurosurgery and lumbar spine surgery, and used very frequent.
Okay, so it kind of clears that space where the nerve comes out.
It does. Yeah. A lot of people say roto-rooter it out.
Got it.
Or you cleaned it out.
Decompression is
Decompression, a more technical term.
And
that's exactly what happens. Removing the roof and getting rid of all the stenosis.
Okay. And is that something where the person can get immediate relief from that, or?
Of course they can. Of course they can. And,
Okay.
and that patient does best with a laminectomy that has the radicular symptoms, the pain into the legs, or problems walking from severe stenosis, which we call neurogenic claudication, which is pain with movement over short distances where the legs get tired, numb, or pain radiates down the legs. In those situations, the laminectomy, people do great.
So can you explain the difference between like a central stenosis and more of the outside stenosis where the nerves are? Is it the procedures the same?
Depends on what needs to be done. When you have terrible central stenosis, usually that's coinciding with bad stenosis over where the nerve roots are exiting. That's called foraminal stenosis.
Okay.
The surgery really is dictated based on where the symptoms come from, and what the approach is, again, is predicated on where the symptoms come from. So if it's a bilateral approach, remove the whole lamina and remove the roof completely, usually reserving that for the more severe central stenosis where it's necessary to open up the channels on both sides. If it's mostly just unilateral or one-sided where the pain's coming from, then coming down just on one side in a more minimal approach, then removing the bone from that side and relieving the stenosis will help with those symptoms as well.
Okay. And when you talk about a standard laminectomy and you say minimal, is it a small incision or is it much larger?
It is.
Okay.
Yeah. Laminectomies, the approaches are varied, and there's plenty of ways to get the same job done, from classic open surgery to minimally invasive surgery,
Okay.
all of which depends on patient preference, ability to get to where you need to get done, but ultimately the goal is to decompress in the most maximal way with the least amount of impact.
I think it's important also to explain to the public that a lot of times they'll have imaging and then there'll be something on the imaging and then they'll say, well, that's my problem. And is that always the case? Or
No,
not necessarily,
no.
right?
There's plenty of data to support as we age that our MRIs are abnormal.
Yep.
And there was a good study 10, 15 years ago where that was documented as you age, if we were just doing MRI of an asymptomatic and a symptomatic patient, there's so much crossover between abnormal reads with either degenerative disc disease or bulging discs or stenosis. It's just dependent on, does the imaging match the clinical symptoms?
Yeah.
That's where success lies in what I do and success for patients.
Yeah, excellent point. Yeah, I get that question all the time in my practice. And I tell people, we don't treat the MRI, we treat you, the person.
Correct, yeah.
So we're going to try to reproduce your symptoms and see what makes you better. And the same is true for a surgery approach, right?
Of course.
So now after a laminectomy, there's some other procedures. There's discectomies. Can you explain what that is?
Sure. Discectomy would be removing a disc herniation.
Okay.
A lot of people always ask, say, Doc, you're going to remove the whole disc. No, we don't remove the whole disc. Remove the part that's herniated. Because when we talk about herniations and discs that are herniated and the symptoms that they cause, 90% of the time it's leg symptoms. Mm-hmm. The back pain, very variable. But those leg symptoms that are associated with a disc herniation, so removing a window of bone to get to the disc is necessary. Then removing that herniation, which is compressing or pushing on that nerve root, that's where the crux of it lies.
Okay. So you're not removing the whole disc.
Not removing the whole disc.
Yeah, so people understand that the disc is, there's a jelly center and then there's rings. So are you sucking out the jelly or just that section that's herniated?
Just the section that's herniated.
Okay. And so when you do that, we see some of these commercials for minimally invasive discectomies versus, is there a difference between the procedures of sucking it out with a tube versus a surgical approach?
They're all surgical approaches.
Okay.
No, there is no difference.
Okay.
There's actually some new papers that have come out recently talking about the different approaches for discectomy and recurrence rates of disc herniation.
Okay.
So you can use that information to kind of inform yourself that regardless of how the approach is done, the outcomes are the same. The risks of reherniation are the same over 10 years. So as long as, again, the symptoms and the imaging fit, the approach for getting the job done is almost irrelevant. As long as it's done correctly, that's the most important thing.
Got it. And in terms of the back and the neck discectomies, is there a difference in the approach and how you would go about that? Obviously, it's a little bit more sensitive area in the neck.
Of course, yeah. In the neck, classically, it's from the front or an anterior approach where we're doing an anterior cervical discectomy infusion or disc arthroplasty to help with that problem. The discectomy by itself doesn't work without something else being done to it.
Okay.
The disc has to be removed from the neck. There have been attempted ways, and there are procedures that exist to remove a disc strictly from an anterior approach or do a foraminotomy from an anterior approach. However, the long-term effects are not nearly as good as doing a procedure up front, such as a fusion or an arthroplasty, to help with the long-term problems that can happen.
Got it. So that's a huge difference, because you can do the discectomy in the lumbar spine or low back
Correct.
without any fixation or metal. But the neck, you have to stabilize it.
Afterwards.
You take the actual disc out.
Correct.
Because it's such a small.
Mm-hmm.
Okay, excellent. So then what is spinal fusion? What's involved with spinal fusion?
The spinal fusion is when screws and rods are placed within the lumbar spine, if we're talking about just the low back. And what happens is usually there's either instability that exists or a spondylolisthesis, or basically a slippage of the two bones in relationship to each other where there's some element of instability. Also in trauma and tumor surgery, that's when spinal stabilization or fusion is used. It entails, again, placement of screws which are placed into the pedicles of the bone, and then those screws are connected to each other with rods on either side.
And then, so when you do that fusion, is there removal of the disc or discectomy prior to that, or sometimes the disc's not even touched if there's a fusion?
Correct.
Can you explain that process?
If the disc is touched, usually, in my hands, it's for that spondylolisthesis, where
Okay.
the disc has to be removed and it has to be replaced with an inner body graft, which helps promote the fusion process, but
Okay.
also increases the height back of the disc space after it's collapsed, as well as helps realign the spine.
Okay.
After that's done, the whole operation is destabilizing, so it's necessary to put screws and rods in afterwards.
Okay. And it's destabilizing because you're taking the actual disc out.
Removing the disc and also removing the joints in the back part of the spine, usually on one side. Once that's done, the whole segment, or that area between two vertebral bodies, including the disc space, is destabilized and then requires the fusion operation.
Okay. Can you show us, do you have a sample of that?
Sure. I have a model here of what it looks like when screws and rods are placed. Now, this is an extensive surgery, basically, where screws and rods could be placed up to L2,
Okay.
3, 4, and 5. This is the sacrum, or the keystone to the spine, where the spine articulates with the pelvis. So when it's placed, the only parts that are showing outside the bone are just the small heads of the screws themselves and the rods in between that connect them.
Okay.
Special little locking caps go inside of the screw heads and help secure the rod to the head itself.
Okay. And then this procedure is a multi-level fusion?
This is a multi-level fusion.
Okay.
Correct.
And typically, why would you do 1 versus 3 or 4?
For multi-level fusion,
Yeah.
The multi-level fusion would be used if you have severe stenosis spanning multiple levels, requiring wide decompressions, adding that destabilizing force, or if there already is an instability that exists. So say a patient has a scoliosis underlying and they've deteriorated over years from degenerative spine disease. As a result, just doing a laminectomy in that patient, we know, has shown that if you don't put screws and rods in that patient after multi-level laminectomies, they'll destabilize their scoliosis over time and be back in the operating room sooner rather than later.
Okay.
So it helps offer the stabilizing force that exists after a destabilizing operation, or stabilizing someone who already has the instability present.
Got it. Okay, so we've already heard about some of the techniques used in spine surgery. After the break, we'll come back and explain a little bit more detail about some more advanced procedures and even some recent advances to help with your chronic back and neck pain issues.
Well, Thomas, you've got prediabetes. But with more exercise and a change in diet, it can be reversed.
I've tried exercising. It just makes me hungry for bacon.
I love bacon, too. And who really likes to exercise?
Not me.
Me neither.
Nobody. So we're good?
What? Oh, you still have prediabetes. Big time.
There's a shelter pet who wants to meet you. Meet one today. Visit theshelterpetproject.org. Adopt.
Welcome back to You and Your Health. I'm your host, Dr. David Bertone. We're speaking with Dr. Howard Eisenbrock, a neurosurgeon, learning about various techniques used in spine surgery. Thanks again, Dr. Eisenbrock, for joining us.
Thank you.
So when we left off in the first segment, you're talking about spine fusion. If you could kindly grab the model again for
Sure.
me. And just, we see that it's fairly extensive in terms of the surgery. What's the recovery like for this procedure?
Recovery for a spinal fusion this extensive, really for all spine fusions, is relatively the same outside of large scoliosis operations. The first 2 weeks hurt, and there's no way to get around that.
Okay.
It's sore, your back's sore, it's painful, the dynamics and mechanics of the spine have changed, so things are different. You're healing from having muscle dissected off of your spine, held back with retractors for a long period of time, in the hospital laying around, muscles get stiff, sore, and painful. After the first 2 weeks, after people are over the hump, and we start talking about exercise, recovery, getting back into shape, getting things moving how they were not moving prior to surgery. Around 4 to 6 weeks, sometimes 2 to 4 weeks after surgery, patients are going to outpatient physical therapy. And that's where we're going to start working on range of motion, mobility, getting things just basically back to get your activities of daily living done. Once that's rolling and the pain starts subsiding from the operation, we start talking about goals of improvement. And really, it turns into getting in the best shape of your life, strengthening your legs, your back, and your buttocks, and preventing problems in the future from happening.
Yeah, I think that's critical because people think that it's, obviously it's a major surgery and it's going to fix everything, and we hope it does, but there's a lot of work involved. And the patient has to commit to it, and things like weight loss and fitness are really critical, because if not, then it's going to fail and they're going to be stuck in the same position.
Correct.
Now, I know there's some controversy about spine fusion, and the public reads about it and hears about it. Can you explain some of that?
Sure.
thoughts? Yeah.
The controversy of spinal fusion is varied from what you read and what you see, but for the most part, the overuse of spinal fusion is known, and people in the community are more aware of it now than they were, say, 10 years ago. Spinal fusion, when used correctly, has good outcomes. When used incorrectly is when you hear the horror stories. It's for those situations we talked about earlier. When you have instability, a spinal fusion works great. When you stabilize an unstable spine, your pain reduces and you feel better. When you have severe stenosis and requires multiple level laminectomies and there's a destabilizing force, that patient does well, having screws added onto that operation because we're adding the stability after the instability has occurred. When used outside of those principles of trauma, tumor, instability, that's where you start getting the controversy of spine fusion, where just back pain being operated on with a fusion. There's only certain situations where back pain only responds to a fusion operation. And then making that correlation back to abnormal imaging outside of the symptoms is where the controversy continues.
Yeah. Great. I'm glad you explained that, because I think people don't understand the point that instability is really the key to stabilizing the spine, and that's why you need the fixation. Now, some advanced athletes have had spinal fusion. For instance, Tiger Woods recently and won the Masters. And so when you do one level fusion and you finally have to fixate that level, what's happening above and below that level? Is there concern there?
Of course there is. In the lumbar spine, the data shows that there's about 125% load increase on the levels above and below. So you have to imagine if you're increasing the load on a segment above and below, it's going to wear out faster. We call it adjacent segment disease. It's a problem, and there have been attempts to improve it with some of the more recent advances in spine surgery.
Okay. So the studies, they're working on it. Hopefully that's
Correct.
something we'll learn about in the future, but that is the concern. And but people need to get fit and
Of course.
Help this problem.
Without a
from
doubt.
Yeah.
While
Yeah.
the spine dynamics have changed, that doesn't mean that the supporting structures around the spine can't be improved. So that's where the physical fitness comes into play,
Yeah.
more than anything else.
Yep.
At 3 months after surgery, you're walking a mile a day after a fusion operation. You just, for your general health, but also to help increase your mobility.
Sure.
You're working out with physical therapy with the exercises you learned, strengthening the abs, shrinking down the abdomen, keeping the legs strong. These help support the spine. If the muscles are strong, we stop the degeneration process.
Yeah, that's great. I think on that note, maybe more pre-op education is vitally important there to get that commitment of the patient, you know, and sometimes that's lacking, I think, just because of how fast things are in healthcare. So hopefully that improves over time. Let's talk about scoliosis surgeries. That's
Sure.
another big area that you work with. So what is the difference when you get to fixing somebody that has a curvature of the spine?
It's a much more detailed operation. In my practice, I don't do juvenile scoliosis or pediatric patients. It's the adult degenerative scoliosis patients. So those patients have either a degenerative scoliosis where over time they've developed the deformity in their spine, or they had scoliosis as a child untreated and has progressed as they've aged. As the discs have worn out, and the joints have become arthritic, and the curves have increased in their significance, is when surgery is entertained. Doing a scoliosis surgery is a big commitment on both sides, from the patient and the surgeon. It's a very long workup, very detailed. We're looking at things such as even your nutritional status before even entertaining an operation. Bone DEXA scans, make sure bone densities are normal. If they're not, it's going to delay surgery 3, 6, potentially 9 months as we put you on medications to help strengthen the bones. Surgeries themselves can take anywhere from 8 to 12 hours. They are extensive. They are very large operations. The recovery is much longer than your simple degenerative surgical procedures that exist.
Okay. And are you using rods in that case to change angles? Or?
Correct.
Okay.
Most of the work is done not so much with the hardware. The hardware is the tool to aid the decompression and the correction.
Okay.
But the correction itself is, while it's different in adults versus children, is that the correction has to occur with bone work. And what I mean is things like osteotomies or removal of certain portions of bone to allow for the correction to occur so patients are able to stand up straight again. This surgery is reserved for people who are severely debilitated from their scoliosis.
Got it.
People who are looking straight at the floor. They're unable to stand up straight, or they're leaning over so badly that their distal esophagus actually gets pinched off and they're unable to eat.
Wow.
That's when surgery is entertained for the adult population.
Got it.
There's also cervical deformities also, what we call chin-on-chest deformities, where people aren't able to look up. So these are debilitating problems, and they require big fixes.
And it sounds like there's a big workup for that in terms of you looking at alignments and knowing where you're going to cut where. And
Correct.
So you're looking at those scans and trying to make that decision beforehand.
Correct.
Okay.
The proper planning prevents, poor performance in that situation.
Great. There's another procedure called KYPHOPLASTY. Can you explain that?
KYPHOPLASTY is used for patients with osteoporotic compression fractures for the most part. And people who have refractory pain towards bracing or conservative therapies like physical therapy, where their pain is not improving or they're still showing abnormalities on their MRI that the fracture is not healing, is when a kyphoplasty can be entertained.
Okay.
Kyphoplasties have to be used cautiously. You're putting a very hard substance inside of bone that's soft, and have to keep in mind that the levels above and below also are osteoporotic. So it turns into that load sharing comment earlier, where now you have a very hard substance against softer substance. And a lot of times what happens is people will develop fractures above and below also, where that cement's placed.
So you're talking about fractures in the vertebral body?
Correct,
itself?
in the vertebral body themselves.
Okay, so the big part of the vertebrae where they're stacked on each other. And then it's some kind of a cement? Is that what's used in there? Okay,
it's a cement.
To stabilize it. So you touched on briefly about the importance of post-op rehabilitation. How about specifically some of the things that you like to see with the patients after they have things like, say, as simple as a discectomy and a spinal fusion, the difference in the rehabilitation process?
As far as their ability to recover from the operation and move forward and get back to work and do their activities of daily living, for me it's a general view where I really like everyone to be at that goal of walking 1 mile a day at 3 months, where I know that that's ensuring that they're exercising. People who are able to return to the gym, if they're able to, some people just aren't. Either physical debilities, debilitation already exists, or what have you. Exercise in any form, core strengthening, yoga, Pilates, avoiding the impact style exercising I think is important.
Yep.
Bicycle instead of run.
Yep.
Elliptical instead of treadmill. Things along those lines, just to
impact,
lessen the impact that's going to exist on the spine over time.
So when we see these patients in physical therapy, we're doing a lot of education, right? So we want to let them know what they can and cannot do, safely perform. prevent the instabilities above and below, work on strengthening, work on body mechanics, and then doing these non-impact activities to get them back to daily living and enjoying life, and hopefully recreational sports. So that helps when they're pain-free, right? When they have severe pain, they can't do that stuff anymore. So let's talk about some of the most recent advances, the disc replacement surgery.
Sure.
So talk about that, and number one, what type of patient are you selecting, and then what's the procedure like?
Sure. So there's two types of arthroplasty that exist, and that's the name for disc replacement.
Okay.
You have cervical disc replacements and you have lumbar disc replacements. More data and better results have been seen with the cervical population than the lumbar population. The lumbar population came out around the same time. The data was not the best in the long term for the devices that had existed on the initial kind of come around with lumbar disc replacement. People do have good outcomes with lumbar disc replacement, but it has to be selected properly. So the workup has to be done correctly. It's that degenerative disc disease patient, that back pain patient who doesn't have arthritis in the joints in the back. So it really selects itself out a lot of times.
Got it.
The cervical disc arthroplasty, on the other hand, has wider indications, in my opinion, where it's the younger patient who has what we call a soft disc herniation in the cervical spine, where it's either compressing a nerve root or compressing the spinal cord itself. Again, with that absence of bad arthritis in the joints in the back, normal alignment of the cervical spine, which is a good majority of patients, that person will do well with the disc arthroplasty.
Okay, and then you would take the cervical disc out, put something in.
Yeah.
I'll
show you.
Let's see it. And do you need to then stabilize that or no?
No. The whole principle behind disc arthroplasty is maintenance of motion.
Okay.
And it echoes back to the whole argument of preventing adjacent segment disease by reducing the loads from a fusion.
Okay.
The data from all the arthroplasties that exist on the market is that they do decrease the incidence of adjacent segment disease. That rate is variable based on the product that's used, and also studies vary in the time for follow-up. For the most part, they're at the 10-year mark now.
Okay.
So the disc is removed fully in these disc arthroplasties. This device, while this is magnetic and comes apart, or did come apart, has a plastic core surrounded by titanium on either side. And this specific one requires a cut in the bone just to hold it in place. Other ones don't do that.
Okay.
And allows for, again, maintenance of motion across the segment.
Great. And from the surgical procedure standpoint, it's similar to doing a discectomy, or is it a little bit more advanced?
It's actually faster than doing a fusion operation.
Okay.
The approach is exactly the same. The procedure up until the placement of the device is exactly the same. The most important part of all these operations is the decompression.
Okay.
Regardless of how it's done, either fused, arthroplasty, the most important part is decompressing the neural elements, the spinal cord or the nerve roots themselves. Afterwards, the goal is to prevent problems, again, at the same segment, and with the arthroplasties, prevent problems above and below.
Okay. And will these patients after surgery require any kind of bracing or anything? Or?
No bracing with an arthroplasty.
Wonderful.
Movement is encouraged.
Wonderful. Wow, that sounds like a really, really cool approach. And you would pick that primarily on the younger patient, healthy joints.
Younger patient, healthier joints. Now, that doesn't mean that someone who's older can't have it.
Okay.
It just has to be selected properly, or else bad outcomes can happen. There's a known problem with these, is that the joints in the back can develop an arthropathy, or basically an arthritis, and become painful with movement. So selecting out those patients who have a deformity in the neck or already have the arthritis present on imaging is important to ensure the success.
Great. Super. Well, Dr. Eisenbrock, thank you so much for explaining, and thanks for coming on the show.
Thank
really
you.
appreciate it. You watched this edition of You and Your Health with, I'm your host, Dr. David Bertone. Until next time and our next topic, we'll see you then.